But I just want to introduce myself. I'm Dr. Cathal McCrory, Professor of Life Course Development and Aging here at Trinity College Dublin. I'm delighted to do the introduction here this morning. Before I begin, I have been asked to bring your attention to a few things. Firstly, just to note that there's two emergency exits in the building, one behind you and just one here to the right. And there's also 3 bathrooms, 2 here to the right and 1 at the back. In the event of emergency, you can see these running, follow me. So I just want to notify everyone as well that this session is being recorded this morning for use in the WHO website. So again, be sure to smile, and love. So just make you aware of that. And finally, I'm absolutely delighted to introduce and to welcome our Provost, Professor Linda Doyle, who's here today. Professor Doyle has been a great supporter of TILDA over the years, and I'm delighted she's even there to launch today. So without further ado, I welcome you, Provost, to the podium.
Thanks, Cathal. I actually, my notes, it said I had 5 minutes, including directions about emergencies. So I misread it, thinking that I was going to have to do some kind of explanation of where everything was. Thankfully, I don't. So I want to start by a huge welcome to all of you, to our very special guests from WHO, from the HRB, from the RSI, and to all of the colleagues involved in TILDA. I think this is a really, really exciting moment. And this WHO Collaboration Centre is such a fantastic thing to say we are now going to have at here at Trinity. And there's just a few points that I want to make about it. But before I do that, I just wanted to say one day, a few summers ago, I was somewhere in West Cork, and I was in a supermarket, and I was checking out the goods, and I looked down, and I needed to write something down for something, and this woman gave me a biro, and TILDA was written on it. And I use that as by way of example, because that is how powerful TILDA is. It has gotten to every corner of the country, into people's minds, into people's thoughts, into people's understanding of how to age healthily. And to me, it came as no surprise that you guys were asked are going to be part of this collaborating centre, because it's something that Trinity is hugely proud of TILDA and all that has achieved over the years. So we are really, really delighted that this WHO Collaboration Centre for Longitudinal Studies on Ageing and the Life course at Trinity College is being launched today. And we do know that the WHO is hoping that 60% of countries are going to have ageing surveys by 2030, and that part of what this is going to be delivering is delivering the expertise and kind of knowledge on how they are best designed, and collecting those best practices around the world. And I think that is a wonderful and laudable aim, and I think it's particularly wonderful as well with the UN Decade of Healthy Ageing. I always say myself, there's many things I could learn from the healthy ageing tips that you guys have, but it is a really important, I think, focus for the world, and we only have to look around to know how big that challenge is. So this collaboration centre is founded, I think, on what I would call a rock-solid foundation. There's been over 71 million invested in TILDA over the years since Roseanne came up with the fantastic idea for it. That's come from our Department of Health. It's come from philanthropy, it's come from the HRB, and it's just really, really fantastic, I suppose, that idea of creating TILDA in Ireland and doing something that matters to the Irish population has been supported in many, many different ways. TILDA has a huge amount to show for that. I think a huge amount that I certainly am very proud of. It has done all the typical academic things that you would expect, which fantastic output in terms of research publications and the best journals around the world. But it has done much more than that. It's been hugely involved in policy translation, and I was looking at the stats. 230 government policy documents, 94 advocacy documents, 191 citations in the Oireachtas, that's the Irish Parliament, for people who might not be familiar with that word, and presented research findings to the Shannon twice. And to me, that's really, really important, that it's not just about the research, it's about how the research gets out there and changes the world around it. So there's been hugely involved in education and training. It's developed a national frailty education programme, which I think is just fantastic. And this is about translating clinical research findings research findings into clinical education and practice to improve patient care. And it uses this train the trainer model, which I think is really, really, again, powerful. And you can see by that, you're not just affecting those people who go on the course, but the ripple out effect that they all have. Of course, it played an incredible research role in the COVID-19 response. It does a whole lot of work on what they call untreated, treatable conditions. I like that phrase, where you recognise that there's these really challenging things that affect us all in life. They're considered untreatable, and they're able to kind of go beyond that and find ways that we can have benefits. It's done an enormous amount of work in terms of health screening. It showed that participants in whom irregular heartbeats, for example, were detected in the study. It looks at things like that and how their lives can be improved, and on and on. And I think, for me, there are two things that ultimately stand out on top of all of the wonderful things that TILDA has done. So there's this fantastic, strong scientific basis on which there is a will to change the world based on that through all of the policy stuff that I spoke about. But there's a deep understanding of what it means to age. And for me, the thing that matters is the fact that they can highlight the impact of social isolation and loneliness on health, those kind of things that kind of move away from, I suppose, the types of understanding that we have about the scientific things about how the body works. And ultimately, for me, the big thing is that TILDA has changed the narrative on aging. So, I think this latter thing is just so important. I think even the way we talk about older people and the words you use about older adults rather than elderly people, every little thing matters in how you talk about aging, Roseanne and Cathal, and everything you do. And with that comes an enormous dignity and respect for people over their lifespan, for understanding all of those things that matter, those biological things and those social things that really, really matter. And, every single time I go to an event that TILDA is involved in, I learn something new and I see the impact it has made in somebody's life. So for me, I'm utterly delighted that this collaborating centre is happening here. I think it's one of the proudest, most brilliant things we do in Trinity is the work around ageing and the life course. And I'm so proud of TILDA and so delighted that this centre has been open today. So I want to wish you congratulations. I want to say thank you to all our collaborating partners and the very best of luck, what I know will be even more interesting output from what is already a wonderful, incredible entity that is TILDA. So thank you.
Thank you very, very much, Provost, for your generous introduction, and welcome everyone to this great day for Trinity, for TILDA, of course, but I hope for the WHO going forward and strengthening our collaboration with them. Joe? I'll use this just. Okay, there you go. Our world is aging. Look at this data. You can see here, up to 2022, the average curve. Look at where it's going. This is global data to 2050. 16% of people will be aged 65 years and over. And that increase will continue to the next millennium, with a huge spread in the accelerated growth of aging populations. For the purposes of Ireland, Europe, and the world, it is clear that Europe has the highest percent of over 60s from this data. But others are rapidly catching up. Their growth will have started later, but the growth is faster. And this is particularly the case in lower and middle income countries, who will depend very much on the accrual of accurate data in order to drive new policies for countries that have had a very slow growth to date in older populations, but it is now accelerating. And the infrastructure to support health and social care in those countries is much needed and should be informed by good data. Ireland has the highest proportion of over 60 in Europe. Or Europe has the highest proportion of over 60s worldwide, but Ireland, our growth, is well placed to lead out on this important new initiative because of our rapid demographic changes. As you can see from this slide, other countries have caught up with Ireland, but we here are still rapidly accelerating. Now, most of us in this room will experience disability, unfortunately, for 1 in every 5 years that we live. 1 in every 5 of our years, we will carry a disability in Ireland. That's a huge challenge. How can we actually address that challenge? 20% of our lifespan. How can we, in TILDA, working with our policymakers and others, reduce that 20% down to 10%? That's our challenge. In that way, there will be less impact and draw on our already pressurized health and social care services. Delaying the onset of these multi-morbid diseases, which, as you can see from here, can be anything up to 7 disabilities after the age of 70 for some people. And how can we work with our colleagues and partners in this WHO collaboration to ensure that this initiative is actually widespread and any of the modifiable risk factors that Linda alluded to are detected early and modified early to compress comorbidity towards the end of life? We know very much that the aging process starts early, and that a host of different factors influence that process. And I know that some of our leading social scientists and economists in Trinity are in the room. The process starts in childhood, and biologically there appear to be 2 accelerated periods during the lifespan of biological aging changes, around 40 and around 60, as far as we know. But the process starts early, and that's why we're launching Aging and the Life course. And the study has already captured a lot of information about the life course, which has led to extant aging processes in Ireland. How can we understand the contribution of children, of childhood, of early life experiences, of early adulthood to ultimately an aging process, and ultimately the contribution that they make to those comorbidities that we're trying to compress and to enable independent living and less disability. Now, if I'm doing a clinic and I'm a 79-year-old gentleman, this happens to me in front of me, and I'm trying to advise him about his overweight, excessive drinking, cigarette smoking, and alcohol intake, I have had the response, I've nothing to worry about, doctor. My mother lived to 90 and my father to 88. I'll be grand. Well, he's not right, because only 20 to 30% of the aging process is genetic, and we can't do much about our genes, not at the moment. We know this from very good longitudinal twin studies. Actually, almost 80% of factors that influence that comorbidity we talked about at the end of life are environmental factors which are modifiable. And that's what a study like this is about. It's about capturing all of the factors, the health, the social, the economic factors which contribute to accelerated aging. So TILDA captures all of that information in its wide omnibus collection of variables, not just genetics and nutrition, but also family networks, social participation, that the Provost alluded to earlier on, loneliness, isolation, education, household structure, income, work and retirement experiences. We can capture that longitudinally, what it's like to retire, how prepared people were for retirement as they were coming up to the process, what their after retirement lives are like, mental health and of course physical health, to understand the tapestry of the experience of ageing in Ireland and thereby inform policy, novel research, and ensure comparability across studies, which will be part of our agreement with the WHO Centre, to ensure that core data collection in all of our partner countries is similar so that we can make comparisons across countries through this harmonised data collection. Collecting health, social and economic information to understand the process across the lifespan. Understand natural experiments. That's the strength of the longitudinal study. We were able to look at Ireland before COVID, Ireland during COVID, Ireland after COVID, Ireland before the recession, part of Alan Barrett's lovely work, Ireland during the recession, Ireland after the recession. So natural experiments offer us an opportunity to understand impact of the unexpected on lifespan through a longitudinal study design. Understand how policy changes made a difference. When a policy is introduced, what was the practice before the policy introduction? What does it look like now? Has the policy made a difference? And of course, cohort effects. When we started TILDA in 2006, Ireland was a different country, demographically, to now. We have very much more diversity in the 45, 50 plus year olds in Ireland now than we did in 2006. What is our today's 50-year-old like compared to 15 years ago? So understanding cohort effects. And we've already influenced a number of government policy documents. It's been cited in Parliament, had Senate and Health Select Committee presentations and reports, and are very actively engaged with our NGO community. So these are the opportunities that we will be able to share with others with respect to longitudinal studies. And it does make a difference, this information, to development of new models of service delivery, which we've been also heavily engaged with our Department of Health and HSE. So, delighted that today has come to fruition. We will work closely with our partners in the WHO to meet their aspiration in this decade of WHO, UN decade of healthy aging, of 60% coverage for studies such as TILDA by 60% of countries in the world by 2030. It's a big ask, but we will work with partners to ensure direction, harmonization of studies, comparability across data sets, to assist with the design, the best practices for longitudinal data collection, good knowledge transfer, and translational output from such studies. Welcome, and thank you for coming. And I'd like to welcome now Professor Alan Barrett and the panel for discussion.
I'll just say a few words from here before I sit over there to chair the panel. So just to say, I want to congratulate TILDA. It's another big day for TILDA. It's lovely from an ESRI perspective to be able to come along and give good wishes and congratulations. So the ESRI, we work closely with TILDA over the years. But from a personal perspective, again, some of you don't remember, I was the program director or whatever from about 2011 to 2013. So I have sort of, worked closely in the sort of the data generation bit. I've had so much professional pleasure and engagement working with the data as well, and producing papers. But now, most recently, I'm a sort of a user of TILDA output because about 6 or 8 months ago, I was appointed chair of a commission on care for older people. And I see Mary McCarron, one of my colleagues on the commission, is here. So it'd be very, very interesting for me actually to sort of transition into a different role and to have a different perspective on what TILDA can actually do. And as you can imagine, on the commission over the last number of months, we're sort of thinking through various strands of that issue of health and social care for older people. And it's when you're in a role like that that you begin to sort of see, if we didn't have TILDA, how difficult it would be to get a sense of what the lived experience is for people in that sort of zone. One other quick point I'm going to make before we go to the panel, I continually stress this when I'm doing talks about the Commission on Care for Older People. If people think this is just about older people, they're missing the point. Okay, on something like the Commission on Care, what we're trying to do is ensure that the policies and the practices are in place almost for the next. Of course, you want to assist people who are currently older. Really, what you want to be doing is moving things, for the next generation. And I always think about it like this: that people should be able to age with a degree of security and confidence to know that the sort of interventions that they might need later on are going to be there and readily and freely available to them. And again, I think that sort of underpins what TILDA is about. It is about health, but it's also about social care. It's about their economic security. And again, security just matters so much, across the life force generally and into old age. So with that, delighted to welcome our panelists. So really what we try to do today, we're going to talk about longitudinal studies of aging, but from a range of perspectives. So we've got Anshu Banerjee here from the World Health Organization, particularly special guest today. It's been great to welcome you here. And Anshu will give us that perspective from the WHO. Cathal McCrory from TILDA itself will talk probably in a little bit more of a detailed way about the study. Marisha Connor decided to take the day off, so luckily
actually just turned up.
just turned up. This is the ultimate in civil service delegation. We're signed up to do the panel, but as delegate, we're delighted that Chris Ryan is here to talk about from the Department of Health's perspective around policy, and then Maria Driscoll from the HRB, and again a particular perspective. So each of the folks is going to talk for a few minutes, and then hopefully we'll have a little bit of time to have a conversation. So, Anshu, can I ask you maybe to kick off and give your perspective of why today is an important day, and the perspective of the World Health Organization on longitudinal studies such as TILDA?
Thank you very much, and first of all, thank you very much for inviting me and welcoming me. This is really a wonderful day for us because we are a life course department in WHO. One of the innovations that was brought into WHO by a new Director General in Southern New York was to bring the maternal and newborn child and adolescent health department together with the aging and life course health department. And so as we merged, one of the things that we are looking at really is, what's the role of the life course and how do we look at this across the life course and what are the influences. And it's something that we are still developing as well within the department to really look at how do we link the different, the work of the different units together from a life course perspective. So secondly, we know that around 80% of people live in low middle income countries, but only 10% of the longitudinal surveys are actually done in those countries. And so there's a huge need for data, as you just highlighted in your presentation. And just now, without data, it's very difficult to be able to set policies and to evaluate policies. And so for these low and middle income countries, we need to be able to support them. And so we've come up with a survey tool looking at harmonization of data, also highlighted how important that is, and ensuring that we have proper definitions for each indicator to be monitored. And we hope that we'll be able to get the support to introduce this in a number of countries. It's already been piloted in a few countries. We've worked with Poland, we've worked with a couple of countries in the Middle East and Mediterranean region to look at how to implement it, and we hope that we'll get funding also to scale this up and really introduce this in a large number of middle-income countries, so that these countries can also identify what the key issues are and how to address that. We've also seen an interesting development in a number of countries in Africa, where in the past they used to have what they call RAMCA or RMNCH, reproductive maternal newborn and adolescent health strategies, and they have now started including aging into that. So, for example, in Nigeria, we noticed that they have a strategy, or they're developing a strategy for, I would say, the life course, looking at the vulnerable populations on both ends of the life course, so reproductive maternal newborn, child and adolescent health, and aging. Zambia, I think, also did that. So it's an interesting development, looking at how we as WHO are starting to bring these ends of the life course together, how some of these low-income countries are also starting to do that, and really looking forward, because we know that they struggle with care for older people, and it's often provided by civil society. So from that perspective, I think we're really looking forward to this collaboration, looking at the experience you've had with TILDA. I was talking earlier this morning as well with your colleagues, and really looking at how you have sort of leapfrogged, let's say, by looking at what's happening in other countries, and sort of looked at best lessons, good practices and lessons learned from other countries to set this up. And so we hope to benefit from this collaboration as well, to support other countries in sort of leapfrogging and being able to implement the surveys and see how to change that into policy and practice. So maybe I'll keep it at that.
Great, very much. Thanks so much for that. So, Colin, might come to you next, and again, across the panel, if you comment as you're closest to the coal face, okay, in terms of the studies. But just to pick up on a couple of Anshu's points there, and feel free to take a couple of minutes to talk about the TILDA and where you're at with it. But that issue of international connection and engagement, and sort of what you're learning from international partners and what you're giving. I mean, I know TILDA is already there, but I'm guessing through this World Health Organization collaboration, that should probably intensify. So if you want to sort of throw some comments on that into your remarks, that would be great.
Absolutely. So I'll start there, Alan, otherwise I was distracted. So as you may be aware, that TILDA is actually harmonised with a set of other studies worldwide known as the Health and Retirement Network of Studies. We're one of the sister studies. We also have one in the north of Ireland called NICOL, there's one in England called ELSA, there's one in China called Charles, and so on. And the idea with these studies, when they first rolled out, was we had harmonisation of measures across the different countries. That means we can look to see how similar the aging process was for individuals across those countries. One of the things that's been beautiful out of Ireland in the past decade, 15 years, is we've had the ability to invest in longitudinal studies across the life course. This includes TILDA, but also includes growing up in Ireland. 10, 15 years ago, back when I was in the ESR, Alan, you should remember, we were important. If I was standing up to give a lecture in Trinity College, we were important data from the UK, we were important data from the British cohort studies and so on, and assuming the same processes were happening here in Ireland, and that wasn't the case. So we now have normative data in Ireland for the first time that lets us know what's typical and normative in terms of aging, and also what's atypical and more likely to be problematic. So in terms of where we are in TILDA was established back in 2009. It was our first sweep of data collection. We're now about to go into the field with wave 7 of data collection. So we've got 6 sweeps of data collection. And just to give you an idea, that encompasses about 15 years of aging. So it's a good chunk of aging, really to look to see what's happening for individuals through that study. One of the things that's beautiful about TILDA is Roseanne's a clinician when the study was first established, and Anshu mentioned this about how we've leapfrogged potentially some of the other studies. TILDA included a clinical health assessment as part of their survey, so it wasn't just questionnaire data that we collected. We had collected objective physiological data. So this includes parameters like your walking speed, your grip strength, your cardiovascular parameters like blood pressure and so on. And as Roseanne mentioned earlier, this allows us to establish, relative to the self-report data, how much untreated need is out there in the community, and that's quite incredible. One of the other things we actually have been very good at doing is we collected blood from our individuals. So we have blood samples, so we can profile biomarkers in them. And we can use some of these biomarkers to ascertain not just how old you're aging physiologically in terms of your walking speed, your grip strength. We can look down there at the cellular, molecular level and say, chronologically, you're 50 years old, but biologically, you're 60 in terms of your blood sample. And I think it's a new way for people to look at their aging, and a way for people to conceptualize their aging. And the other amazing thing about these things is because we follow people over a long span of years, including right up until they die, we're able to ascertain that these measures, measured 15 years ago, predict who's going to die, who's going to get disease, how early we're going to get disease. We're still at the early stages of it, but they may have clinical utility into the future. This idea of precision medicine, we're going to usher in that new era of precision medicine. And the final thing I want to say, just in terms of the novelty of what we're doing, is we talk about the life course. And what I've always said to people now, they have a tendency to think aging studies, as you mentioned, just something that happens at some era in the future. You're old when you're 60, you're old when you're 70, and so on. And I'm always telling people, let's reconceptualize aging as a continuous developmental process that starts at conception and continues up to the close your eyes for the last time. And it's nothing's immutable. Roseanne suggested 70% of that is under our own control and environmental factors. And there's things that we can do to change even the trajectory you're on. I've got 6 waves of data now, so I spend a lot of my time looking at the data and seeing how the developmental trajectories for individuals are changing. But you can see massive variability in it. So you have the average for the individual, and then you've got some who are doing really well, and then you've got some who fall off a cliff. Between wave 4 and wave 6 of the study, something really changed for them. So I look at someone's walking speed and realize they had hip replacement. That's the reason why they slowed down a lot and so on. So we've got potential to do a lot of these studies to help inform how people age, how people age more healthily.
That's actually, this one is working. So we're going to turn next to Chris. And actually, before I get you to comment, I think again there is a value in congratulating the Department of Health here today. I mean, as somebody who has spent a career trying to convince civil servants to fund various bits of research, I know this can be a battle, and often there are tensions. But I think it is worth saying it is quite remarkable that over a prolonged period of time, the Irish Department of Health have invested in TILDA. And there were some sort of economically troubling times, during that period. So it was never absolutely guaranteed that this would sort of carry on. But I think tremendous credit to the Department of Health for staying with it and funding it. I'm going to use the term generously. I'm sure Roseanne will always say it's not generous enough, because that's always sort of part of the toing and froing. But no, it's been fantastic. So Chris, I'd like you to talk a little bit about the actual impact that TILDA has had on policy, but I'm going to throw a little supplementary in there that I'd like you to think about. And it's around this idea that we know government departments tend to work in very siloed ways. Okay, and of course the philosophy underpinning TILDA is we should be thinking about health and economics and sort of social connection, and a whole range of things should be thought about together. But of course, each department tends to focus on its particular zone. So if you want to throw in a comment or two about the extent to which the TILDA lessons have percolated beyond the Department of Health, I think that would be an interesting, and again we can come back to the discussion. But over to you.
Well, I was glad to step in from Merge actually today, because I was involved in, I suppose, some of the decision making around the extension of TILDA. And I think it was a great result to get the additional 3 waves in 7 years. And that gives a level of security now that we can go and really plan for what the outputs and the deliverables might be over that time frame. And I think there has been a huge impact on domestic policy, and I think it is a program that has an international significance with kind of top 25% most cited academic publications. But I think that I suppose the challenge for the department is how do we use this really rich body of data and really generate the evidence that can inform the decision making that has to take place. And I think some of the charts that Roseanne kind of put up kind of showed the trajectory that we, along with much of the Western world, are on, and it is an aging trajectory. And as an economist, I'm kind of one of the dismal scientists in the department. I tend to follow the money, and the money tends to follow aging as well. And I think if we are going to be able to deliver healthcare that's kind of fair and equitable and accessible, that has to be done with a kind of a rigorous pursuit of public health measures, which maybe kind of keep people healthier for longer and less of a burden on the healthcare system, and then also productivity and efficiency, and to the extent that the interventions that are taken by the health service are actually delivering the desired effects, because there's no point in us doing things that aren't actually going to support people to live healthier and longer lives. And I think some of the contract changes or contract elements that we got incorporated this time will kind of support that better linkage between TILDA and the department. So we'll have a coordination group which links some of the older person policy units within the department. That will help maybe with some of the agenda setting, kind of linking some of the policy questions back into the research questions that individuals will be able to tackle. We'll have a placement of a TILDA researcher within my unit, within the department, who will kind of be able to do more immediate research on behalf of the department, but also link the department to individual researchers within TILDA who have expertise in particular areas. And then separately, we have a PhD from Galway, who I think is involved in Galway, I think they're involved in TILDA. But they're looking at, for us, they're looking at the comparability of TILDA data with a new infra single assessment tool. And that draws in some of the TILDA research that's been undertaken to identify kind of important elements like frailty, and to see to what extent data is now going to be captured by the infra, which will be compatible with the TILDA, so that we'll be able to kind of do joint policy making. And I think two other things. One, the transfer of the existing data and the forthcoming data to the CSO will actually lead to a much richer data set. It'll be good for Trinity because of the headaches around data protection. Well, some of those will disappear. But it'll be good for other researchers, and linking into some of those wider fields like housing and transport policy and social welfare policy, because maybe some of the drawbacks of the TILDA data set to date is maybe some of that socioeconomic information isn't as fully captured as some of the health and clinical data. And if we can link up some of the TILDA data to the existing administrative data structures within the state through the CSO, it will provide a greater richness, I suppose, for academic research to support policy. And finally, I suppose, just a shout out to the HRB, who were phenomenal during the I suppose, negotiation of the new contract. But we also have developed a new bespoke evidence for policy call, where we're working with policy units to kind of clarify the sort of research questions that they feel are going to be important to support decisions that will be taken in, say, 3 years' time. And then they're put out to the academic community and they'll be funded through this bespoke funding model. But it's a way of maybe kind of giving others access to some of the TILDA data, and also to be able to fund individual research projects and have a policy.
Great, thanks a lot, Chris. So we're going to come to you finally, and obviously the HRB sits in the right at the centre, directing sort of health research within the country. So again, feel free to sort of comment on TILDA, but where does this the study fit into the sort of the broader strategy for health research funding in Ireland? So over to you.
Thanks very much, Alan, and congratulations to Roseanne and the TILDA team on the event at WHOCC Operations Centre. It's a great achievement. I think what we're trying to achieve, much what we've heard really speaks very, very much to the HRB strategy, because what we're trying to achieve in HRB we're trying to inform policies and strategies in healthcare and make sure the decisions are underpinned by the evidence. So that's what we're all about. And that's all about providing policymakers with kind of clear evidence that they need to make those decisions. And I suppose in doing that, then we're trying to create very much an understanding of the value and impact of research. So I guess ultimately we know the HRB as a funder And of course, our portfolio does include lots of projects and programs and universities and hospitals, and all about improving health and care. And that involves supporting people with research career paths, and of course, as you know, we've invested very significantly in health research infrastructure, particularly around supporting trials. But our interest actually goes beyond that. It goes beyond the funding research part. It's important, of course, that is, it's absolutely fundamental. But we're also very, very committed to promoting and enabling the use of data to shape health policy. And I suppose that brings us into that whole space of how do you use data and evidence to support policy, how do you incentivise those links between the research community and the policy community. And I suppose there's a number of practical ways that we have done that in the HRB, and I'll show you in a minute. But we have, of course, our own evidence centre, which helps to generate evidence to inform decisions of policymakers, and we work very closely with the Department of Health on that. And they complete every year a number of evidence briefs around that. We're going to be doing one this year on health and social care services and sports for older persons. We also, just want to mention this far as well, we manage 4 national health information systems in certain areas: disability, drugs and alcohol, and inpatient psychiatric care. And we use those to engage in a lot of knowledge brokering work. For example, we're very heavily involved in citizens assembly recently on drugs, but in other areas as well, in the drugs form. And as Chris mentioned there, the new evidence for policy programs, we took it one step further earlier this year with this new evidence policy program, which was co-designed with the Department of Health, and that's all about harnessing academic research to address policy needs of the Department of Health. And then, of course, longitudinal studies play a huge important role in that as well, and we recognise their value. So, I mean, TILDA, of course, is, as we've heard this morning, it's one of the largest awards actually that's managed by the HRB. And I think it really exemplifies that evidence for policy approach, because it really just corresponds to that need for quality data to inform policy and practice. The reason the HRB is involved at all, of course, the study is funded by the Department of Health, but we sort of entered the picture, I suppose, at the request of the Department of Health in 2016, and that was to manage the contracting, manage the award, manage the review processes, all of those really important things. And I suppose what we brought to the table was our experience in research assessment and monitoring and oversight. And that's all about making sure that research that is funded stays there at the forefront as international practice and continues as an exemplar around the globe. And I think TILDA certainly does all of those things. So 2 years ago, we commissioned an independent evaluation as part of our role of managing this. We commissioned an independent evaluation of TILDA, which was very, very rigorous. And the overall conclusion, you won't be surprised to hear, is that TILDA is very high quality, invaluable resource both nationally and internationally, and it's certainly a critical evidence base to support policy making on current and emerging issues. So it acknowledged, I think, that TILDA is very highly regarded by peers internationally. Of course, that's reflected, I think, today in today's designation of TILDA as a WHO collaborating centre. I have to mention the other longitudinal study, of course, that we also funded, because I know Karen is here in the audience as well, and that's ITS TILDA, which is follows people with intellectual disability as they age. And I think it's very interesting to have those 2 longitudinal studies based here and led by teams in Trinity. It's just interesting to share their experiences, and I expect that will be further enabled by this designation as well. And there's a multiplier effect with all of these longitudinal studies. We find as these are funded, we see in other parts of the HRB, as we put out calls for funding, more and more quality applications come in for funding. So you see this really very impressive multiplier effect from these longitudinal studies. So I suppose, what does all that mean for us? I mean, in terms of what we've learned from our experiences in HRB about linking using evidence and data to support policy, the importance of good relationships, I think, is really, really, really crucial, particularly that sort of two-way communication between the scientific community and the research community and the policy community. And I suppose that takes a little bit of time, because people do work in these different worlds and they work at different times, they have different pressures. So I think one of the things we've been learning out along the way is how we can work to support that and I suppose broker those kind of relationships. And it does take time, just turning those policy questions into sort of actionable research questions. I think does actually take a lot of time, and we've been learning a little bit about that through our Evidence Policy Programme and bringing the people along with us. So I think it's really important for the research community also to try and understand the needs of policymakers, and I suppose that means educating ourselves about the policy life cycle, and we heard a little bit about that, and Roseanne, you mentioned about that as well. And I think it means, designing initiatives for different points in the policy life cycle as well, which is really important. Whether you sort of big broad reviews or you're testing the feasibility of intervention. So it's important to understand the policy life cycle and where you can interact. But I suppose just to finish, a couple of other observations. I mean, this is a really big interest now across government. The whole question of how you use data and evidence to support public policy. It's a key action in Impact 2030, which is our national research and innovation strategy. So lots of government departments are interested in this, and I think G. Barris is taking a lead on this. And I mean, longitudinal studies are going to be so important in supporting that whole agenda. There is an issue, I think, around how we fund these, and notwithstanding that we have, fortunately, and thanks to the support from Department have been able to fund TILDA and indeed ITS TILDA over many years now. But I think it is important that they're seen as key infrastructures. And what we're increasingly seeing in the funding scene is that, our funding models aren't always fit for purpose at the moment. We need to think about how we fund those key infrastructures, including things like longitudinal studies. Going from, I suppose, one grant to the next is not always the best way to do it, and I think that creates huge challenges for teams, and we're very, very conscious of that in HRB. That's not a criticism of all the Department of Health, but I think they've done absolutely fantastic work with both TILDA and in funding TILDA and IGS TILDA. I think it's a question more broadly for government as a whole, for DFARS, for the Department of Higher Education, and really just it's a whole of government question. How do we actually, we need to see a lot of these R&D initiatives as part of core infrastructure to support the state. And I think that's a conversation that we need to have. So I'll stop there.
Great. Hopefully we'll have a couple of minutes to get questions from the audience. We might need to talk about that. But before we go to the audience, I'm going to come after you, Andrew, if I might. Because one of the issues that has come up, and it comes up all the time, okay, which is this policy, academic research policy interaction. I mean, I think we're always talking about this, and loads of seminars and everything like that, and everybody understands that academics do what academics do, policymakers do what policymakers do, and it's been motherhood and apple pie. Everybody says, "Oh, we need to get these groups," but it is a constant difficulty and a constant battle. Just curious from your perspective, have you solved it? Have you got bits of advice as to how this interaction can be organised most fruitfully?
So we've got one concept, health and all policies, and that's really, I think, addressing also your question you had about how do you get the research findings and decisions making introduced in other departments that are related, because as highlighted also earlier, this is very much a multi-sectoral approach, and it's a multi-dimensional issue. It's not just only a health issue, there are so many other things. So if I just look at the decade, looking at age-friendly environments, how we support that, that's not, in many cases, a health issue. That's looking at long-term care and social welfare, how do we introduce that? Looking at integrated care for older people and ensuring that communities are engaged. So that's one area, I think, and whether that has solved the discussion, I don't know. We often start saying that health is a political issue, and it's a political agenda also that drives policy making and interests. So I think it's also a matter of the voice of older people, which is one of the cross-cutting issues within the decade, for older people to voice what their needs are, and to make it potentially also a political issue so that politicians want to engage because they feel it's important for them. So this is one of the things that within WHO we're always struggling with, in the sense of the political lifespan is short. And what is it that politicians are looking for? And how can we influence that agenda? And so, what is it that you can bring onto the political agenda? So, yes, research very important, the policy dialogue very important, but what's the trigger for the politicians and parliamentarians to act is something that maybe the voice of all the people, the voice of society can raise.
Great. Okay, would anybody like to throw in a comment or a question? And we get a microphone. We do the usual thing of a name and an affiliation.
One of you, I'm Mercer Connor. I was the person meant to be where Chris is from the Department of Health. So first of all, thanks a million to Chris for standing in so ably for me at absolutely zero notice. And congrats to Roseanne and the full TILDA team right across Ireland for the further investment in 3 phases, which is fantastic, and for the development of your international engagement. I'll be brief because I could talk for ages about TILDA. It's just hugely valuable. It's a major investment by the state, but it's really, really valuable in particularly the whole of person approach and the life course. I think so much of our other sort of expensive research in health and social care is very disease specific, or looking at a particular medicine, or even a molecule. So I think the reality of aging is one of multimorbidity and complexity, where mental and physical health interact and so forth. And that's captured wonderfully in TILDA, and that's really rich. And Alan, we take your challenge, and we all do here, to bake it into our planning for services and to understand, I think, ultimately the effectiveness, as Chris says, and efficacy of our healthcare interventions. One of the stats that's always been sort of good for us in Ireland is the perceived health status. Our self-perceived health status in Ireland has been remarkably high. I think almost champions of Europe, I would say, on a regular basis in that. And it's one that's given us great comfort, along, of course, with the ultimate one, the longevity and life expectancy where Ireland is done well. But even where we've been hammered and come under genuine pressure with things like access and waiting, those things have come true. And TILDA is the only resource where you can look at self-perceived health status against those clinical tests. And just that's really, really valuable, and something that can inform smaller scale studies, just that core evidence. That sort of the clustering of chronic conditions is really the reality. The Minister had an interview with Sean O'Rourke there, just at a HSC event last week, and he told an anecdote where he was down, I think, in Waterford and meeting patients of a new cardiology care pathway. And some alpha came up, and the Minister said, how do you think of this care pathway for cardiology? He says, it's the best thing ever. And the Minister said, how did it benefit you? He said, I got a new hip. But it just shows like that man needed to walk to maintain aerobic exercise for cardiology. Anyway, like I say, I can go on for ages, but it's a guide. We commit to further sort of baking it into policy practice. We have the European Health Data Space. We have a commitment to make everyone's information available back to them. So things like TILDA inform us about what are the key items of information. And then in the health literacy space, how people receive and digest information. And I see Teresa Werder, who has moved a lot of these issues into TILDA over the course of our management of it in HRB and in the department. So thanks. Sorry for it.
Great. Thanks a lot. Anybody else like to make a comment or a contribution? Yeah, see another hand here.
I'm the research community mentor, so it's Corey Fallon in medicine here. I've been very fortunate. I'm an immunologist, okay? And pre-TILDA, I published on aging, we're in Cambridge, I published with Queen's in mice, okay? I'm an immunologist, but I could do it in mice. I could not do it in patients, humans. And the transformation of TILDA is, as an immunologist, and chronic disease is information. It starts before the ball. So as an immunologist, we want to make discoveries. I go to work to make discoveries that will impact human health. Now, the situation is when COVID happened, everybody in the world worked with COVID. They had one problem. They couldn't access elderly people pre the virus. So you couldn't do assays because once they're infected, And TILDA is unique all over the world. People could tap into TILDA because you access to sera cells through the pandemic. So we could access our papers with TILDA on patients from different hospitals. But the reason why we could make impactful research discovery was TILDA was here. So the question about how do you engage research and social change, what have you, you make it and research will come. You've got a world-class research bioresource here, unmatched. Again, beauty here is that all the countries are doing it, and the focus is on change for patient health, etc. But as a scientist who sets out discovery, TILDA's position, scientist in Ireland, to compete internationally. So I'm very fortunate that 4 or 5 years ago, I grabbed Roseanne and said, "You're wasting time, it's inflammation, grip strength, no. And I've learned so much as a pure basic research. I'm a translational technologist, looking at my cells, patients. And I think for the audience, this is a great opportunity for Ireland. We can make research discoveries that impact the world. So congratulations all.
Space for we get Richard one last round.
I'll keep it short. I'm not sure. I might be leaving away from that coffee. As Roseanne eloquently said earlier on, healthy aging, health and well-being at older age is, of course, related to some of the genetic endowments that we have, but the majority of the variation is explained by the environment. And that is a very broad set of different factors. And one of the, I think, really important things about these types of longitudinal studies is that they give us measures of the requisite environments that contribute to health and well-being and the way that they interact with those objective measures at the biological level and the epidemiological markers that we then have about health outcomes. But it's important just to underline the fact that it's not just about those individual molecular measures. We need measures of the environment, high quality measures of the environment, and good research which tell us what are the important domains of that environment that we should be looking at so that we can do the kind of targeted research that can then inform policy. Because it's really, we're not going to be able to change the genetics for most people, okay? We might be able to subsequently intervene in some way to ameliorate some of those genetic endowments, but what we can intervene on are the environments. And that's not only in terms of the environment, so like polluters, for example, how policy might intervene there, but we can intervene in ways that change the very motivators of the health behaviours, which are often the targets of policy. So policy is often about smoking cessation, moderation of alcohol consumption. But actually, those behaviours occur within a social and economic context. And it's important to understand what that social and economic context is, how it drives the behaviours, and how it begins from a very early age. How those things are happening from conception, but particularly those really important periods in early life, possibly in infancy, but definitely up into puberty. So I just wanted to put that out there as a sociologist who deals with those environments all the time, that's an important contribution of TILDA and these types of HRS family studies.
Can I just say one final, just as a note on that, Richard, so I absolutely take your point. We talk about where TILDA's come from, but just to give you an idea where TILDA's going to. So we have a grant of our partners in HRS, the gateway, the local gateway, the AG, and we're looking at these environmental exposures. So in TILDA, we have geocoded all the addresses that people have historically ever lived in. And now what we're doing is we're linking to the rich historic data where it's available, things like climates. So we've got rain, precipitation, temperature. We can also link to things like radon, so the ESRI, construct our colleagues in ESRI. Things like when the smoke coal ban came in and so on. So we're actually looking at some of those exposures, light pollution, green spaces, blue spaces. So we can look at the impact of those broader, what we call the environmental kind of measures on you, but in addition to the individual measures, whether it's smoke that people drink and so on. Because we recognise that there's a macro environmental exposures that go above just these initial exposures that you take when you smoke, when you drink, when you're physically active, and so on. So that's our next move. The other one, someone was talking earlier about, loneliness and so on. We're now also looking at what causes people to flourish as they feel older, right? So you might look and say X% of the sample have depression, X% of the sample have loneliness. The vast majority don't, right? And then we're actually starting to look at what's responsible for flourishing? Is it an interpersonal factor, like your personality, like your ability to cope with stressors and so on? Is it interpersonal? Is it your social network sizes and so on? Or is it something economic or elsewhere, job satisfaction and so on? So that is the kind of next phase that we're moving into between phases 7 and 9 is to continue to grow that resource, expand it out, and hopefully research will come to it.
Yeah, Chris, you want to do?
Yeah, I would just say if we're talking about challenges for TILDA in the future, I think one of them would be taking the samples that have been collected and seeing if we can get them profiled, whole genome sequenced, because I think it is the interaction of the genes and the environment which is really important. And I think internationally it would be an incredibly rich data set if we were able to look at the interaction of genes and environment and risk factors over time. Like we're involved in the 1+ million genomes at the European level, and I think when I talk to international counterparts, it's that epidemiological information over time and the correlation with the genetic coding, which is really important.
Okay, I'm under strict instructions to bring things to a close because I know there's other important events to happen. So with that, Rosanna, I'm going to hand back to you.
So just for me to say thank you for everybody's contribution here today and to come back to the WHO and our role there. I mean, it may not be immediately evident, but we started with a blank sheet in Ireland. We did not have an extant infrastructure on which to grow a longitudinal study. We had no panel from whom to draw, etc. And as the studies have evolved, it has created research infrastructure in the country. So we feel very strongly that we're in a position to help guide others, particularly our lower and middle income country colleagues who will be struggling with similar challenges. And hopefully we will see much more of each other. And Shin, thank you very much for coming. Thank you for recognising Ireland, Trinity and TILDA, and looking forward to many years of flourishing. Thank you.